Good afternoon. Thank you all for coming today virtually. I'm really appreciative for everyone's flexibility last minute. We're apparently every 10 years, there's a cataclysmic ice storm that we need to be accounting for in January. So that's a scheduling oversight of us that 2026 was the time that was supposed to happen. My name is Nate Nessel. I'm a physician, a pediatric oncologist. I treat kids with cancer here at U of M. I'm a clinical assistant professor in the Division of Pediatric Oncology. I primarily work in Kenya, and it's a great privilege and pleasure of mine to have this meeting today and this conversation with some great friends and colleagues to talk about global cancer. I hope we can really just stimulate a strong dialogue amongst ourselves here to talk about global cancer, how we're thinking about it, and what are the opportunities we can really innovate this in an impactful way to really advance cancer care delivery for all people in all places. So I wanted to just remind everyone we got a lot of questions during the registration process that were incorporated into hopefully the conversation today. So we won't have the opportunity to give questions during the time, but hopefully you could have your questions addressed during the conversation. Following this, if you have an unmet question that we weren't able to address, there will be a link at the end for you to give us your feedback. We like to hear how it went, and then for you to also give your comments on those questions. And then also, if you're interested in getting connected to doing more global cancer activities here at the University of Michigan, that would be a spot where you could engage in that way. So it's my pleasure to introduce Dr. Gifty Kwakye. She's going to be our fireside chat moderator today, and I'm really excited that she's agreed to do this. She is a colorectal surgeon here at U of M, working to improve the surgical capacity training at Ghana and abroad. So Gifty, take it away for us.
Thank you. Thank you so much, Nate. Hi, everyone. Welcome, and thank you so much for joining us. I hope wherever you are, you're staying warm and you're safe. I have to confess, I was really looking forward to this fireside happening in person, because I think there's something really nice and cool about being in person and being able to look each other in the eyes and having a great conversation. And I think that's going to be my challenge today, is to try and draw aspects of being together, even though we are now in Zoom land. And so I'm going to try and make this as interactive as possible with the panelists that we have here. So I'm really fortunate to get a chance to be on this stage with some incredible people. I'm going to introduce them very briefly, and then over the course of the discussions, draw some additional aspects of what they do into some of the questions I'll be asking. But in no particular order, I have Dr. Satish Gopal. He's a medical oncologist and the director of the Center for Global Health at the National Cancer Institute. I have Dr. Nickhill Bhakta. He's a pediatric oncologist with the St. Jude Global. Dr. Lauren Wallner is an associate professor of internal medicine and epidemiology at our Rugal Cancer Center. And of course, we have Dr. Samir Saini, who's a professor of internal medicine and director of the VA Center for Clinical Management Research. So thank you for all being here. Again, I appreciate you all being so willing to pivot into the Zoom virtual space, but still being so excited about engaging in this discussion. And I'm hoping to learn as much as I can from you all. So we have a few, I'm going to throw out some guiding questions, but really, again, we hope that this will be sort of a conversation style thing. So if another panelist makes a comment and you're like, I really want to follow up with that, please feel free to do so, and then interrupt me here and there. I think that lends itself really well to creating this small conversational field. So the first question we're going to start off with is, there's a lot, I think we all are used to various terms coming up from time to time. Global cancer seems to be a buzzword lately, but I think like a lot of things which come up, sometimes not everyone has a shared understanding of what a particular term or phrase might be. I was thinking, preparing for this, is similar to the 6-7, where I'm still not sure what 6-7 means, but everyone uses it. And I'm wondering if instead of defining global cancer, that maybe we can make it a little bit more practical and in terms of what you do on a day-to-day basis, breaking it down that way for our audience today. So instead of defining global cancer, how can we relate it to something that you already do? So let me start off with, let's see, Satish. So thank you again for being here. I know you've done some incredible work in Malawi, and currently you work in the NCI. So I'm wondering if you wouldn't mind sharing with us if there were any moments during your work in Malawi or what you do in the NCI that changed how you think about cancer disparities and how you think about that phrase, global cancer.
Sure. Well, thank you to the University of Michigan CGHE for inviting us. Very sorry we couldn't do this in person, but we'll look forward to doing that at some point in the future. Thank you, Gifty, for moderating. I think Zoom moderation is not an easy feat, so we thank you for taking this on today. So really grateful to be here. And maybe I could just start. 6'7" doesn't actually mean anything. That's the point. So we can get that out of the way at the beginning. And there have actually been some hilarious articles about this in the New York Times and the Washington Post within the last couple of months that I can refer you to. In terms of a seminal point or moment in time, one that I often bring up, I've written about this, I've talked about it, I sometimes include it in talks if it's appropriate, but I think it's actually more a personal story. Is one of the most harrowing things that happened to us when we were living abroad. I lived and worked in Africa for about a decade before being recruited to the NCI in 2020, is that in 2016, when my younger daughter was 7 years old, she nearly died of cerebral malaria. I've written about this a lot. She dropped her hemoglobin to 5, had her spleen in her pelvis, was, extremely sleepy and confused. And it was really harrowing. And I broke the vials of intravenous artesunate and gave that to her myself on the bathroom floor and slept with her because she wasn't in an ICU as she would have been at the University of Michigan or at the NIH or at the University of North Carolina where I was before. And I raised this. She's recovered. She's a healthy, thriving, incredibly audacious 16-year-old now. So that's the end of the story is good. And I thought a lot about it then and think a lot now about kind of what that experience meant to us in relation to global health and global cancer, because this wasn't really a choice that she made. She was exposed to malaria because I had chosen to take her abroad in pursuit of my academic global cancer research career. And I think what I thought about a lot is that ultimately her life was saved because she received intravenous artesunate, which was tested in clinical trials that African and Asian children volunteered to participate in, that demonstrated clearly that intravenous artesunate is better than quinine, which had been the previous standard of care for severe malaria. And so as a result of receiving this intravenous artesunate, my daughter, an American citizen who happened to be living abroad at the time, her life was saved. And so I think this was an example by which we as Americans benefited clearly from evidence that was generated in part by children living in other countries. And I think a lot of my work before then, and in some ways this reconfirmed my commitment to trying to ensure that everyone has an opportunity to participate in and benefit from research. I think the reality is that often people around the world have had opportunities to no opportunities to participate, or when they have had opportunities to participate, haven't benefited in direct ways. And I think a lot of what we've thought about with our programming at the NCI in recent years, given the enlargement of cancer burden globally, which is principally occurring in low and middle income countries, and that will continue to be even more true in years to come, is how to enlarge opportunities for scientific discovery and increase opportunities for people around the world to participate and benefit in cancer research. And I look forward to elaborating on some of that as we proceed in the conversation today. Thanks.
Thank you, Satish. And I'm so glad your daughter is doing well. I'm really grateful that she's doing well. As someone who grew up in Ghana and had malaria so many times, it's sometimes easy to forget that it can be such a devastating disease. And and I'm really grateful for all the breakthroughs that have happened in that space. So thank you for sharing that very personal example here. Why don't we go to Nickhill next? So Nickhill, you work with the St. Jude Global organization, and you collaborate with pediatric oncology teams across many countries. I'm wondering if you could share maybe a story or a personal moment or an experience that helps show you how challenges in global cancer care mirror what we see in resource-limited settings here in the US.
Yeah, no, and thank you, Gifty, again, to reiterate all that Satish said. Thank you for moderating. I really am. I wish I was there with you guys in person. I was looking forward to being able to travel and be with you all. I think to me, this is really I'll take a step back from like the micro, think more macro. We're kind of living in a very interesting moment in the global pediatric cancer space, or just in the global cancer space. I think there's been a confluence of really exciting synergies that have come through. And they've ranged everything from now all of a sudden getting recognition at the WHO level from the Global Initiative for Childhood Cancer. I remember sitting in the basement with our colleagues from the WHO and literally on the board, just trying to figure out like, what are we going to make as our ambition here? And, kind of making it up and saying, well, I suspect there's probably global survivals around like, I don't know, 20 to 30%. Let's just go with 60% and say we're going to double it. And well, that adds up to about 1 million lives if we do the math by itself. And now it's become a challenge at the global health community that's really been adopted, such that even when I go to conferences now, it's really exciting and satisfying to see partners from around the world starting to just cite back those kind of ambitious goals that we have developed from the global initiative all the way now to at country level and hospital level conferences, kind of everybody buying into the energy and the enthusiasm that we're seeing. And then the second is really thinking about how we've really been able to build a true global network around in this space. And so, I always like to say the thing about what separates the pediatricians from the adults, at least on the oncology side, and I say this with a little bit of a wink at Satish, is that pediatric oncologists are generally nice and we like each other. And so, we all care of we all work with kids, and it's true that pervasive personality, and that's true also that in terms of that collaborative space. And what you've seen, I think, in the pediatric community that has been so incredibly inspiring over the past 7 to 8 years has been this real kind of amalgamation and confluence of efforts to really improve outcomes for children everywhere. And I mean that literally in the sense that we all have examples that we can highlight where we've identified either outcomes or interventions, everything from just how do we safely provide needle sticks without causing trauma or anxiety to children, tested those in resource-limited settings, and now all of a sudden have brought them back to St. Jude because our teams have been like, how come we don't do that here? All the way to novel diagnostic tools that have been developed in resource-limited settings and now are going through LDT processes here in the United States because, well, they're just better than the things that we have currently. And nobody really thought about doing that because unlike the motivation that is being primarily pushed on by economics and resource-limited settings, here it's just about layering more on top of more, which may not be the right answer. And so, I think as we look at that, we now have these global things like our St. Jude Global Alliance, which is over 400,000 hospitals in 90 countries, probably representing over 1/3, a reach being over 1/3 of the children diagnosed with cancer around the world. And that really is allowing us to think about things in a novel way and really put community and put health outcomes in the same category, and allows us to really innovate in ways and scale in ways that we've never really thought before. And that's really what's been, I think, exciting to see over the last several years, at least within the childhood cancer movement.
Nickhill, I think your point about complex networks and then leveraging a complex network to come out with really great outcomes and innovate is really a great point. And I can't think of a more complex network that has been extremely successful and sustainable than the VA system. And then I also thinking about how it spans a lot of different settings. I've worked at VAs where they have a lot of resources, and then other VAs where there are limited resources. So maybe, Samia, I can bring you in on the conversation here because you lead a lot of work in our VA here at Michigan, and thinking about how do you see or think about global cancer, but as it pertains to global being local in a VA system with different sort of resources, a complex network.
Yeah, thanks, Gifty, and thank you to you and to everyone for the opportunity to be here today as well. Yeah, so I practice at the University of Michigan, also at the VA, and as Gifty mentioned, I run the Health Services Research Center within the VA. I'm not here as a representative of the VA. I just want to say that up front. But the VA is it's a unique a large integrated healthcare system, delivers care to almost 10 million veterans across the country. Has a lot of advantages as an integrated system. Both through integrated electronic health record system, and I think through a shared mission. Where veterans are really at the center of everything that VA is trying to do, and really all the practitioners and everyone really working within the system knows that. And I think that's really one of the things that allows the system to do what it does and deliver the high quality care that it delivers. Um, I think one of the things that I think, just reflecting on sort of the global, sort of aspect of this, that I think, sometimes, maybe people don't realize, both inside and outside VA, when I'm thinking about cancer care delivery, is the extent to which, the care that we deliver every day in routine day-to-day clinical care, and have been delivering in routine day-to-day clinical care for decades, is informed by the work that's been done by, our scientific networks. And we talked about networks already today, but our scientific networks and our colleagues from across the globe. Our cancer prevention for colon cancer, for example, is heavily informed by, the microsimulation modeling work that the National Cancer Institute funds here, but has been, it's done overseas, some of it, and much of it. I just spent a month in the fall over in Europe with some collaborators, start trying to advance some research in that area. I think, on the scientific side, this sort of global, sort of research network is something that I think is remarkable, and I think sort of having all hands on deck is something that I sort of see as being one of the true sort of crown jewels and strengths, of the work that we do in this space, and I think something else that the NCI helps to support and fund as well. And that is work that comes back to, our day-to-day clinical care across the country here in the U.S. and certainly within the VA as well. So I'll pause there.
Thank you. Thank you so much. And I think you highlight a very important point, even when you're describing your roles. I think like all the panelists we have here today, we are clinicians, we are researchers, we are public health specialists, we wear so many hats, but that reflects the interdisciplinary nature of the work when it comes to global. Anything global requires all these multifaceted roles. And I can't think of it, when I was looking through the bio, I was like, Lauren, you probably have all these different niches, these different spaces or hats that you wear in a very unique combination, if I was to put it that way. It's like the clinical care, epidemiology, population health. I think it gives you a unique perspective that I would love you to weigh in on this question here. Like when we think global cancer in the spaces and all those multifaceted spaces that you sit on, the hats that you wear, interested in hearing about your thoughts on global cancer and how it shows up in your space.
Well, thank you, Gifty, for moderating and for the invitation to join you all today. This is a wonderful panel. So yeah, I really have had the great fortune of working across disciplines in all of the work that I do in cancer care delivery. And I think, how we are studying and measuring and identifying disparities and what we're doing to address them, whether that's locally or globally, has changed quite a bit over the course of my career to date. I think we began where we were really spending a lot of time trying to describe disparities and, just identify them, characterize them, particularly by race, ethnicity within the U.S. in particular. And I think, we finally are shifting away from that now after a long stint of characterizing disparities to now really being focused on trying to design, evaluate, and implement solutions to try to address them. I think that really does come with making sure that you are working with interdisciplinary teams and that you're partnering with folks from the local communities in which you're trying to implement these solutions. I think both in my work that's done here based in the US and through various collaborations globally, these solutions that we are trying to implement to address these disparities really are made, they're either made or they're broken by understanding that local context and making sure that you have buy-in from local partners, right? And so, I'm just thinking and reflecting back on the time that I've spent studying disparities as part of all these different teams. I think, it's really, really important to leverage those partnerships, but to also make sure that you have the right stakeholders that are represented at the table, and that you really do understand the complex nature of some of these disparities that we see in access to care, because it's not typically just driven by race, ethnicity, for example, right? These are all intersecting to influence access to care both globally and locally. And so really trying to design solutions that address multiple aspects at once, I think is where the bang for the buck is.
Thank you, Lauren. I think it is a nice segue into another topic I wanted us to discuss. You mentioned disparities, and I think a lot of folks have complained about the fact that a lot of research has gone into describing the problem, stating the problem over and over, and what people are eager for is solutions. Like, how do we innovate in this? How do we change this such that we don't keep on repeating and seeing the problems we've seen in the past? And when we think about global cancer, this global space, we've done a lot of describing. But even in the intros to the first question I asked, all the panelists today brought in solutions. I think we touched on solutions here and there. We talked about how things have been developed in one space, but then also translate in another space. And I wonder if maybe we can go there and unpack that or discuss that a little bit further. So when we think about reciprocity, when we think about innovation in global spaces, instead of describing the problem, let's talk about solutions. And let's talk about solutions that we have seen actually work. So this is not something abstract, but something that we can bring to the table and say, I have seen this as an example of an innovation that reflects bilateral reciprocity, thinking about global, but also thinking, again, global being local. So either from a low resource setting in the US being translated into a high resource setting, or a low resource setting globally and translating into a high resource setting here in the US. So I'm going to ask each of my panelists to give us an example of maybe where they've seen that either in their direct work that they do or in working with some of their collaborators, innovations that have, carried forth really well. So why don't I start with Nickhill? Let's have you go first this time.
No, sure. The challenge is just deciding on which one to necessarily highlight. And I would also just posit there's just to use up other parlance, north-south, south-north. But what I think has been truly exciting, again, as we think about more integrated networks, is south-south. We're starting to see more and more of our global partners. We do these engagements. We start with these innovative projects, and then we start to realize that they're disseminating out further. I mean, I talked about early warning scores, I think, in this. I'm sorry, it's been a long day. I can't remember which meeting that I talked about this particular, but one of the things that we started working on, because we recognized that early clinical deterioration was a challenge in many of our oncology wards, and so we started to implement early warning scores in many of our partners listed in South America and now globally. That led to a recognition that St. Jude wasn't doing that, so we pulled that back in as another one of those kind of here. And then actually now that's gone to all of our affiliate centers as kind of a quality improvement project. But what that has led to is actually reformulating this culture of quality improvement. And so while we started these in oncology wards, what's been super exciting is that we've seen these early warning systems now permeate from the oncology ward now into the general pediatrics wards and then going into the adult wards as well. And nothing to do with us, just fundamentally changing culture and kind of adopting and identifying this culture of quality and culture of change, which has been kind of infectious throughout the various departments that we work in. And we've seen this over and over again in multiple settings. So I think that dynamics part of it has been really exciting to watch, which is not just only kind of an intentional like north-south or south-north or what have you, but kind of seeing the potentiating effect and seeing the dominoes continuing to fall across the board in terms of actually making these impacts across these different health systems that we work in.
Thank you. Thanks for sharing that. Do you mind if I ask a follow-up to that? I'm always curious in terms of how we change culture and how we get things to really work. Like taking an idea from one space, how do you then have another space adopt that? That what makes that innovation in one south then translate into another? What works in this particular situation?
So I'm going to answer that in two ways. So I think that there's the kind of realpolitik way of how things truly work in the world, and there's also kind of the more like structured answer. So the more boring answer is I think you have to show what works. You have to like build relationships. You have to build trust. All of those things which are true. But I will say that in the amount of work that we've done and working across networks and partners, there's nothing more motivating than FOMO. And I mean that in the sense of that true fear of missing out, seeing that either your colleagues or others have had success, that breeds success. And that's really been impactful as we've seen really simple interventions, whether it be mucositis management, whether it be pain control management, whether it be early warning scores, whether it be fever and neutropenia, guidelines, et cetera. They all start, there's an inertia. There's a coalition of the willing that you identify that really are open and willing to work with you on these kind of small idea projects. But then that hint of success, then you start having them presented within your webinar networks. You have those presented at like your regional conferences or your professional conferences. People always start like, wait, they can do that? How come we couldn't do that? And that's not just a they kind of situation. That's also, like I said, at St. Jude, like, wait, they're doing it over there. How come we're not doing it here? So it sounds silly, but I'm not joking. Like FOMO is probably one of the biggest motivators in not only the global health space, but within healthcare in general, in terms of helping to really motivate. But it's got to be done in a way that highlights and identifies that positive message and puts partners up front, because no one's a king in their own kingdom. And ultimately, when individuals are up there and talking about the work that they've done and talking with pride about the success, that motivates so many others to say, I can do that and I should do that.
I love that. I love that. Although this year I'm embracing JOMO. That has been my thing because I've been living around. But I do. I really like that and I appreciate it. I'm thinking about the work I do in Ghana around colorectal surgery, and certainly that has been the motivating factor. Like no one wants to be left behind. Everybody wants to get in on the action, and it certainly works when leveraged appropriately. So thank you for sharing that. Lauren, why don't I ask you that question, the same question then, in terms of that bi-directional innovation, how you're seeing it practically play out in your space, and then giving us one clear example of it working.
Yeah, I think, so our research group does a lot around patient-facing interventions. And, we really do try to meet patients where they are in their local contexts. And so I've definitely seen this bi-directional play out when we think about how we're delivering those interventions. So for example, leveraging mobile technologies is a good example of that. So, here in the US, we've kind of gone all in on leveraging mobile apps or, optimized websites for the mobile phone to reach patients directly to help support them in their cancer treatment decision-making, as an example. And that content, while there's some, applicability in other settings, the mode at which we're delivering it may not work, right? And so while we, in certain settings globally, a mobile device delivered, intervention might work well, there's some where we also have to have, you know, a one pager that's translated into a variety of languages to try to deliver the content. And, you know, I think what you learn is, again, partnering with folks on the ground to really understand and getting those stakeholder perspectives early on in that tool development and, you know, your plan to roll it out is really, really critical, because I think that's where that adaptability comes, but that's also where that bidirectional learning comes. Because, you know, at the end of the day, at least in our case, like that core content that we're delivering through these interventions is quite similar, and it might be culturally adapted, but it also has to be adapted in the mode in which we're delivering it potentially.
Thank you. I'm thinking about some work we had done around mobile prompts and running into issues around which operating system do you use, and you know, do you use an Android or not? Even like simple things like that, because you assume everybody has a phone about the platform, and then is it an app or is it not? So even simple things that are great in one space to not necessarily translate. And I think you made a great point about having the local stakeholder, because if they are not involved or at the table, then it's very hard. You spend a lot of time working on something that might not necessarily work. So thank you for bringing that up. Samir, let me go to you next. Practical example.
Yeah, I mean, I think, you know, maybe one example that comes to mind, you know, I think there are certainly global applications of this as well, but I think some of this was really motivated by the pandemic more than anything else, has been the resurgence of stool testing for colon cancer screening. You know, I think, you know, most of us know that, you know, there are kind of two dominant or two, you know, widely used strategies for colon cancer screening. There's colonoscopy, and then there's different types of stool, you know, sort of screening tests available as well, which check for really primarily for blood in the stool. And in many ways, you know, I would say that in general, what had happened over time is that colonoscopy had kind of become the desirable test in the eyes of most practitioners, you know, in some ways, the public, I think, had kind of, you know, seemed to have gravitated in that direction as well. While, you know, the guidelines continue to recommend both, the evidence certainly, you know, did not endorse one or the other. And then, you know, during the pandemic, I think, you know, motivated in part out of necessity as people started to move to telehealth and you know, we started having fewer in-person visits, we saw this real, you know, I think more of a shift towards stool-based testing, and particularly towards more, you know, the more modern tests. You know, we have, you know, the fecal immunochemical testing, FIT, you know, some of the Cologuard, which is, you know, sort of a FIT DNA-based test. And then, you know, sort of organized programs as well start to pop up more, you know, sort of, you know, sort of the mailed programs, which you know, have existed for a long time in some parts of the world. But you start to see some of those start to emerge as well. And then another innovation that, you know, has kind of, again, always sort of existed, but really had sort of started to take off more, was sort of looking at sort of quantitative data from these tests, how much blood actually is in the stool, as opposed to just saying that there is or is not blood. And it turns out, obviously, you know, looking at quantitative information in stool testing can be quite useful, just like it can in anything. You know, is your hemoglobin, you know, high or low versus is it 7, 11, 15? You know, that can be pretty useful if, you know, if you were to look at that. And it, you know, this turns out to be, you know, quite useful and quite portable as well. And you start to see its value in rural areas, and, you know, certainly in other parts of the world as well. And, you know, I think, you know, again, it's kind of a low tech feeling solution, you know, and you know, that's finding some very valuable applications. And I think can, you know, is changing the way that we practice in some sense.
I think that's an excellent example. Of course, as a colorectal surgeon, I'll think that is excellent, so, because it's right up my alley. But I wonder why we don't see innovation like that being adopted or used more widely. because it is lower cost overall. But Simi, why do you think something as simple as that is not being adopted? Like, I rarely have recommended a stool-based test to any of my patients. I do
I mean, it does depend. I mean, it's a good question. I mean, it depends to some degree on I mean, again, if you look, the guidance is quite clear on this, and that the best test is the one that gets done. And there are parts of the country, there are health systems where certainly those tests have long been recommended. In the United States, my understanding is that there's not an FDA approved way to get quantitative information about how much blood is in a stool test. So that is a limitation in this, that's not readily available. Perhaps it is available in experimental conditions, but so there are limitations like that exist. Yeah, I think much of that is driven probably by practice culture, some of it by local culture, things like that as well. And of course, to some extent, financial incentives, things like that certainly play a role in this as well.
Yeah, absolutely. I feel like I'm not, from a colorectal surgeon, I'm not incentivized necessarily when you think about what brings in most money. But maybe what we need to adapt is what Nickhill brought up about the FOMO. Maybe coming up with a process where some of these more innovative, simple innovations become the cool thing in town, and then we get other people to want to join that band with all that process. So thank you. Satish, coming over to you now. I'm sure you've been waiting your turn eagerly here and have had a chance to think up an innovation. So
yeah, so there are too numerous examples, I think, to mention all of them. And, and I think this is something we should get better at as a community. We should get better at kind of articulating the places where this has had big impact and get better in terms of framing the argument. But just to name a couple, I mean, I work on lymphoid malignancies, and the reason we know about Epstein-Barr virus as the human oncogenic virus, the reason we know about MYC as one of the most commonly mutated human oncogenes, which remains typically non-druggable across a range of cancer types. The reason we know about multi-agent chemotherapy as a curative regimen for at least hematologic malignancies and lymphoid malignancies in particular is because of collaborations that began in Uganda in the 1950s and 1960s when Dennis Burkitt discovered this unusual tumor that we now know as Burkitt lymphoma, which led to important NCI-supported collaborations actually to try to pursue those lines of investigation and learn as much as we could about based on the opportunities that were afforded by that specific cancer type. Another good example is the human papillomavirus vaccine. The reason we have a vaccine that is now delivered to pre-adolescent boys and girls in the United States to basically eliminate their risk of HPV-associated cancer is because of collaborations that the NCI initiated with colleagues in Costa Rica many decades ago. And those have continued to the point that just a few weeks ago, I think a couple of weeks ago, there were published results of a definitive randomized controlled trial demonstrating that one dose of the vaccine was equivalent to two. So essentially, kids around the world can have lifelong protection against HPV-associated cancers from a single dose of HPV vaccine. And that's obviously really beneficial to children in the United States as well as people around the world. Maybe just one more example is there's a really rich tobacco policy research that has, I think, illustrated even beyond knowing that tobacco was a carcinogen and knowing that tobacco reduction has yielded major improvements in morbidity across a number of cancers at a population level in the United States, most notably lung cancer. How to achieve that at a population level, I think, has really benefited from cross-national study of policies that have been used to influence tobacco control. And I think those have generally demonstrated that things like taxes and laws have more population impact than individual cessation behavior, right? And that's informative, I think, for the policymaking community. Now, individual countries will have to decide what they do with that, and there's different political will for different solutions in different environments. But a similar experiment is ongoing now with respect to social media in Australia, as you probably know, that kids younger than age 16 are restricted from social media accounts. And I can say this both as a health researcher and as a parent of teenage daughters. I probably speak for many parents of teenage kids around in the United States that I'm intensely interested in what the outcomes of that large-scale experiment will be. And so I think the idea that there are not concrete examples just is a little bit silly. But I think it is totally understood that, you know, we need to get much better at talking about what the benefits of these kinds of investments are and the ways in which they influence health here in the United States as well as around the world. So
Absolutely,
And,
absolutely.
and I'll just add, I mean,
Yeah.
maybe just to say, I mean, I
Samir,
totally
go
agree
ahead.
with what Satish is saying. And to some extent, I mean, you can really look at any, I mean, this is in some ways a scientific point, you know, largely as well as like, you know, really like, you know, if I look at any grant that I write or any paper that I write, I'm always, you know, building off citing work that's been done by researchers from across the world, right? I mean, it's like that is like a natural, and it's never it's one of the places where there's no passport or border involved in any of this, right? PubMed is you know where we're sharing ideas, and that is you know I think an essential part of how we do the work that we do.
And thank you, Samir, for jumping in there. I think that's an excellent point. And again, drawing on this, like trying to make this as interactive as possible. I think you all highlighted some great innovation that's happening. And I think what is very clear is that this has been happening for a while. There's been this bi-directional transfer of information. I think we don't do as great a job highlighting, especially when it comes from a lower resource or not a traditionally expected space. I think it's easy for us to highlight things that happen in our spaces or more resource heavy. So thank you for drawing out all of those different examples and then showing this has been going on for a while and the opportunities that exist in different spaces. I want us to pivot a little bit, continue the discussion, but recognizing that a lot of our audience today come from different schools around here at Michigan. So I think we have about 15 or so schools represented or disciplines. So not everyone is a physician or does cancer-based work or research, but they are here today because they're genuinely interested in the subject. So thinking about that interdisciplinary component and how we can give them something to reflect on how they can be part of this work that is happening. You all work in spaces where you're working with collaborating across different spaces. So from your perspective, how can we have interdisciplinary people involved in this global cancer work, however you're defining global cancer? Why don't we start off with Lauren?
I actually think that's a great question. I'm a team scientist by heart. I work across a number of different teams locally and, you know, what feels like everywhere sometimes. And I think we can get folks involved in this kind of work in a number of ways. I think one is having opportunities to support this sort of cross-pollination locally, whether that's like pilot grants that have some criteria that you are working from different schools or different contexts and you come together with an idea. And so we've tried some of those sort of, you know, seed funding opportunities to spur ideas and new collaborations. I would encourage folks to reach out directly to people who you know are working on these types of projects globally, locally, wherever, and, you know, just having conversations about mutual research interests. That's where a lot of the interdisciplinary collaborations that I'm involved with have come from. But then also I think sponsoring others is plays a big role here too. I think as a mentor, you know, and sponsor, we have an opportunity to try to connect the, you know, more junior folks that are working with us that are interested in this space with, you know, different teams that are working on some of these, you know, harder, more complex problems globally and locally. And so I think there's a lot of ways that we can come at it. But I think it is really sort of the backbone of a lot of the work that we're talking about doing today is those interdisciplinary collaborations and teams that are doing the work.
Thank you. Nickhill?
Yeah, no, and I think that cancer is a great example of this because from a medical health delivery standpoint, it already is multidisciplinary in so many ways. So our challenge is not to be multidisciplinary, it's to be transdisciplinary. But there's already a culture there, working radiation oncologists, surgeons, pediatric oncologists, pathologists, radiologists, nursing, social work, et cetera. We're all already functioning in multidisciplinary teams. The question is, how do we then translate our research and expand to leveraging our social scientists, our mixed methods scientists, our implementation scientists, et cetera. And so that's why I think that unlike maybe other disciplines, we have already got that core value of team science inherent in how we practice. But we all know that clinical delivery of medicine is not the same as actually being able to deliver quality medicines, quality health delivery across the globe. And so there we have to think about multidisciplinary, multi-level, all the way from health policy, health systems financing, all the way down to, yes, quality of care, quality improvement, implementation science, to thinking about the social disparities and how everything from financial hardship to financial toxicity to really understanding the sacrifices that parents are having to make, at least on the childhood cancer side, or at least on the adult side, how families are having to make decisions based on their other competing health interests, as well as social and financial interests. And so that spectrum, there's so, and I think you highlighted, we got to find solutions. We got to move from talking about the problems to finding the solutions. Part of the opportunity here, though, is that unlike I think the decades of leveraged health research that we've done in the communicable disease space, in the non-communicable disease space, and thinking about cancer within that as a component of it, there's so much we still don't know. There's still so much foundational research to be done. I mean, you look at just like financial hardship or financial toxicity, almost all of the foundational research has been done in breast cancer survivors in the United States. We've been trying to figure out, okay, does those same models that we understand about behavioral, psychosocial, and material hardship actually translate to children and their families or not? How do we engage, not just doing a systematic review and research, but actually engage families and patients and survivors with lived experience in deciding those frameworks? And then how do we figure out how do opportunities like navigation or conditional financing programs really focused on and supported by foundations and many of these different resource settings actually come to bear? And what is the evidence to actually support the best decision making? And then how do we marry that with business plans? How do we marry that with budget impact analyses? So automatically, you have to think outside of just simply, if you want to like actually address this, it's not as simple as, okay, St. Jude has a global drug access program, which is a global fund. We provide drugs to Ghana, which will actually be one of the next countries I'll be providing drugs through this platform. Getting drugs to the airport and then into the hospital is not enough. How do we make sure that the patients are still coming to get those drugs? What's that last mile component of actually getting into the family's homes, et cetera? That's where the real research barriers are at this time. And that fundamentally requires us as cancer researchers to rethink what is research. I don't know how many times I've been told, well, that is secondary science by colleagues in the cancer research world. And we talked about it this morning with some of the trainees, how oftentimes people are discouraged from going into the social sciences or into global health research because, that's not the way you do it. Like, you're supposed to go into a lab, you're supposed to spend your 2 years understanding the basic mechanisms of science, and then it's okay that you'll never use any of those lab skills. Somehow that's okay, and that you're going to somehow become a competent methodologic researcher in this domain. So we have to rethink our education in this country and what's acceptable and tolerable, and that requires us. I think we're seeing a lot of that change. I'm not trying to cast shade on anyone, but there is still that challenge that we face as a community about how we do this, and that's, I think, the cultural change that's underway that's going to hopefully allow for further acceptance of team science, and also not just acceptance, but really, in order to do anything innovative now, it's got to be in a team science way.
Thank you. Thank you so much. And I'm going to have Satish and then Samia, you go next. But Satish, I'm wondering from the NCI standpoint, like thinking again about these interdisciplinary opportunities, especially for our audience members. I know there are physicians there, I know there are researchers, but are there other folks in that NCI space who are working on some of this work that do not belong to those traditional groups that we think about typically? And then Samia, it will be pertaining to our U of M crowd here, thinking about opportunities for folks to get involved who are not necessarily physicians or PhD researchers. Okay, so Satish first.
Sure. Well, thank you. Cancer care and research is multidisciplinary, transdisciplinary team science. Global health care and research is also multidisciplinary, transdisciplinary team science. So there's just no way that one could pursue this discipline without, I think, some level of multidisciplinarity to it. And actually, that's one of the reasons that I am really have been attracted to work on global cancer for much of my career. I think we're largely living with a global health infrastructure that was created by HIV response. And I think that has really important capabilities and really important shortcomings. And I think if there was to be a really serious global cancer research and control effort, as you're starting to see emerge, I think that is actually the next big step change opportunity for global health in terms of system strengthening. So for all those reasons, I think we're proceeding down a very likely productive and impactful line of inquiry. How you enable that, I think, is, to some degree through what you all are doing with this Center for Global Health Equity. I think you have to create a nucleating infrastructure because it's very difficult for people, especially if they're new to the field, who may be the people that you're most interested in attracting, but don't, because they come from a new discipline or have new ideas, to navigate all of these complexities on their own. So I think if you can provide them with opportunities for convening and getting networking, strategize about some key opportunities that there's consensus around within your organization to pursue, provide catalytic funding to initiate some work and generate some preliminary data in some of these areas as CGHE is doing. I think that's incredible. And then help with some of the inevitable logistics that arise, right? Travel, IRBs, regulatory stuff that is often quite difficult to navigate. It's not enabling to have to learn that each time again, right? As if it's new. And so you want to create some shared infrastructure and experience. And I think if you do that, you can really realize true team science and leverage some of the incredible capabilities that exist across the University of Michigan.
Thank you. Thanks, Satish. Samir?
Yeah, and sorry, Gifty, you wanted me to talk just a bit about sort of
the interdisciplinary opportunities here. And I think Satish talked about the CGHE, but just expanding that because you know the local environment a little bit better too.
Yeah, I mean, I do think, I mean, I'm agree with all these great comments that everyone has made. And, I do think here, I mean, certainly CGHE is a great, sort of resource and opportunity. And then IHPI, obviously, from a methods and sort of, community and collaborator sort of engagement standpoint, I think is critically important. I also think, we've talked a little bit today about, I mean, we've talked about how valuable it is to meet in person, for example, right? And the importance of meetings. And, then again, the pandemic has kind of, sort of reaffirmed that for many of us as well. I think particularly for those who are early career, I think, figuring out, which meetings to attend, and which ones are the high yield, high value meetings that you should, attend regularly. And who your people are in a sense, who your community is and where you can build relationships. In the work that I do in colon cancer prevention, there's the World Endoscopy Organization. So, that group focuses on colon cancer related work. The name is kind of funny. When I first heard about that, I thought it was an endoscopy group. And I was like, do they do technical endoscopy work? No, it's actually very much, kind of a global group of cancer researchers that gets together once a year in the US and then around the world at other times. And it's a very small group, and it's a very, collaborative group because people that do this type of work are very, very collaborative. And so figuring out, who that is and where that is and talking, if you're early career, I think talking to your mentors to sort that out is really important because you tend to gravitate towards the big meetings, which are important. They have a role, but those smaller ones are the ones that you might not, necessarily know about or it can often be very important as well. And they may not be on your radar. They might be on your radar if this is very much your focus, but sometimes it's not the focus. And I think that's actually quite important to figure out, how do you build those relationships? How do you find your people in the field that you're doing work in as well?
So thank you. Believe it or not, it's almost an hour. We're almost done. Time went by real quickly, and I know we touched on a lot of things. I just want to highlight some buzzwords that came out. Of course, global cancer. I think we've made it as practical as possible for our audience. There's a lot about collaboration, which came across in each section. Everything we discussed was about collaboration, but also realizing the power of innovation that happens when we take the time to just listen, to engage with our stakeholders and be open to exploring those opportunities. And I think also what we've talked about now, the collaboration by interdisciplinary opportunities, we can only move forward with solutions, real solutions, if we integrate folks from other disciplines. So for all the members in the audience who are not physicians, who are not cancer researchers, we really need more of you involved in this work to make us effective or impactful on any level. So thank you. I want to say thank you to our panelists. I know this took some time from your busy days. We appreciate you so much, and thank you for all the work you're doing in all the different places. The impact you're having is tremendous, and I just appreciate that. And I do want to use the time to introduce Dr. Akbarwalji, who's the director for our Center for Global Health Equity. So Akbar, you have a little bit of time there. Sorry we didn't leave you some more, but thank you so much, everyone.
Yeah, no, please. And Gifty and Samir, Lauren, Nickhill, Satish and Nate, thank you so much again for all of this. I'll close by saying, first of all, this was not only something that we brought together people from the Center for Global Health Equity, but from IHPI, the Rogel Center, again, just speaking to the importance of partnership and engagement across campus. Sometimes it's easy to get siloed into our different worlds. But this is an important way to acknowledge that we certainly have the same common mission, vision that we just need to pursue. With some of the things that I heard today, that we'll certainly as a center go back and reflect on, is really try how to increase sort of the transdisciplinary work that's going on campus. What I will say, and I'm hoping that we're moving towards this, is that we really want to make sure that we support our early and mid-career faculty, right? This is a crucial time where we need to leverage a sort of resource to help support them, to make sure that they continue to remain doing work in global cancer, which again, I'm going to remind people that global is local also, and that there's a lot of ways for us to learn from each other. And this idea of reciprocal learning is going to be really, really important. AI and using of innovation and technology, data science, I think is a strength that exists and is also cross-disciplinary. And so I think leveraging those components, I think are going to be extremely important. Satish talked about decreasing the barriers to engagement. So I think some of you may note that we have two funding mechanisms twice a year. One's a seed grant for $35,000, and then there's another impact accelerator grant for $100,000. There's about a 40-50% chance success rate if you apply for it, and it's not burdensome, right? We're asking for roughly 3 to 5 pages of work. And I think that's really, really important. We also have a data collaborative that's very strong that also provides additional funding around how to leverage data across different groups. And we actually, again, I'm not trying to reinvent the wheel, right? We work with ICPSR, another great entity on the University of Michigan campus that houses tons of data sets. And our data collaborative with the lead of Christina and Josh Ehrlich are really driving sort of that momentum forward. We still want to hear from all of you. What could we do better? What could we do more? So feel free to reach out to us, because we certainly want to, increase that collaboration. As far as it comes to meeting each other, we are going to bring Satish and Nickhill back during the summer, maybe have a community gathering, have all of you engage with them, and really try and facilitate, what I believe and truly believe is a great university that can do so many things in conjunction with partners like Nickhill said. And so we're looking forward, Nickhill, to engage with. So Jude, Satish, we'd love to see you back on campus again. 1 minute to go and spare here. So thank you all for your engagement.